Pleasant morning to you all. My name is Dr. Belinda Matibura, and I'm honored to present my dissertation titled Adherence to Cervical Pre-Cancer Treatment in Harare, Zimbabwe. And this was a mixed methods study. This work was supervised by Prof. Chirenje, and I declare no conflicts of interest. Cervical cancer remains the fourth common cancer among women globally, yet it accounts for 23% of cancer deaths in low and middle income countries. Every year, thousands of women in low resource settings are screened for cervical cancer, but far too many are falling through the cracks between diagnosis and treatment. Bringing you home, the burden is particularly high, with 68 new cases which are diagnosed per 100,000 women. This is dating 2022, and a death rate which is 12 times higher than the global target. In Zimbabwe, even with a national screen and treat program in place dating 2012, only a quarter of these women are able to receive treatment on the same day. The data on adherence, predictors, and system-level barriers remains limited, especially from the patient's perspective, hence the importance of this study. The objective of this study was to explore the clinical, social, behavioral, health system factors which influence adherence to cervical pre-cancer in Zimbabwe. They were split into two: quantitative objectives and qualitative objectives. From the quantitative wing, I sought out to describe the clinical and social demographic characteristics of women who screen positive for cervical pre-cancer. I also sought to determine the proportion of women who are adherent to pre-cervical cancer treatment within a 30-day window. I also tried to identify and analyze factors which are associated with treatment adherence. And from my qualitative objectives, I wanted to assess the barriers and facilitators of patient adherence to cervical pre-cancer treatment. And lastly, I was looking to examine how women's beliefs influence adherence, and this was structured based on the health belief model. We conducted a sequential mixed method study at Mbare and Epworth polyclinics, and this was dating from September 2024 to March 2025. From the quantitative, we looked back into records of 172 women. Data collected included the demographics, the clinical characteristics, and whether treatment was completed within the 30-day window or not. And from this data, we did logistic regression and identified the predictors of adherence. From the qualitative arm, we conducted interviews of 20 participants, and data saturation was reached at this point. And the participants were purposefully sampled, looking at those who were both adherent and those who were non-adherent. Thematic analysis was then done, which was again guided by the health belief model. Ethical approval was sought with the Joint Research Ethical Committee and the Medical Research Council of Zimbabwe. So the key findings, which are depicted on this slide, which is showing the socio-demographic predictors of adherence based on the quantitative data, we found that married women were significantly more likely to adhere to treatment, suggesting the importance of partner support or household stability. Secondly, HIV-positive women had the highest adherence of approximately 95.6, likely due to the better health system inclusivity of these women and their engagement, and the more frequent health provider contact. And from this data, we also see that contraceptive users were also likely to adhere, probably reflecting proactive health system behaviors. In contrast, people who were referred for the loop electroexcisional procedure, this was a strong barrier which was picked up in this study, with only 79% of the non-adherent women, with nearly 79% of the non-adherent women being referred for the procedure. This was statistically significant and reflects a system-level barrier linked to possible procedure availability and fear. Interestingly, age was not a significant predictor, highlighting that behavioral behavior, and system access may outweigh individual characteristics. From the key results, we've also found that overall adherence was approximately 91.9, which is remarkably higher than what is comparable to other studies, which note 5 to 77%. And same-day treatment was achieved in 82% of women, and HIV-positive women had the highest adherence rate. Looking at the predictors of adherence, multivariant analysis was conducted, and referral for LEAP emerged as the strongest negative predictor for adherence, with an adjusted odds ratio of just about 0.08, reflecting that 92% of the women had low odds of actually completing their treatment within the 30-day window. And this highlights possibly the influence that treatment type has on patient follow-up. Meanwhile, other socio-demographic factors like age and education were not significant when adjusted for clinical variables and health system factors. Health belief model and the phenomenological experiences, which we call lived experiences of the patient in the qualitative phase, were applied. And women who adhered often described strong perceived severity and susceptibility, saying things like, "I knew if I delayed, it could turn into cancer." They also cited cues to action, such as counseling, peer stories, or clinician follow-up. Non-adherent women, on the other hand, had fear, also had misinformation about the LEAP procedure, and mistrust in the follow-up system. These results were triangulated, both the qualitative and the quantitative. For example, the quantitative data showed that the LEAP referral was a negative predictor, and the qualitative narratives revealed that women feared excisional procedures and who were deterred by scheduling delays also did not turn up. Similarly, HIV-positive women had higher adherence, both because of regular clinic attendance and probable stronger provider relationships. Taking all of this together, our findings suggest that the system design, which is same-day treatment, HIV care integration, combined with empathetic, empowering communication, significantly drives adherence. It's not just about access, it's also about trust, familiarity, and reducing the fear in our patients. This study had several strengths and limitations, there were some strengths which increased the validity of this study. And I'll note that the first strength was that we employed a mixed methods design, which allowed us to triangulate the statistical findings with lived experiences. Secondly, we integrated both the health belief model and the phenomenology, giving us deeper behavioral and emotional understanding of our participants. Thirdly, the use of the urban VIAC clinics demonstrated that high adherence is actually achievable in the real world setting where these programs are implemented. However, it was not without limitations. Our non-adherent group was small, limiting the multivariate power of this study. We also had an overrepresentation of HIV-positive women, which may also reduce the generalizability of our findings. And given that this study was focused on urban settings and well-researched clinics, which is Epworth and Bare, it might overestimate the adherence compared to rural clinics. That said, the high HIV positive proportion may actually reflect the population that is mostly engages in screening, making the finding especially relevant for policy and service planning in Zimbabwe. To conclude, this study demonstrated that high adherence is possible. In fact, over 90% of women in our setting completed treatment within the 30-day window that we had advocated for, defying the trends which have been seen elsewhere in the region. But more importantly, we learned how this happened through empathetic care, integrated services, and strong provider-patient relationships. At the same time, barriers like misinformation, fear of the LEAP procedure, and poor health literacy still persist and disproportionately affects vulnerable women. The message is clear. Systems alone don't change lives. Trust, accessibility, and culturally sensitive care does. If we can scale these lessons across our screening programs, we won't just improve adherence, but we might save lives. I'd like to acknowledge my co-supervisors, Dr. Mreva Nema and Dr. Guja, and the Awaken ED, who supported this study. Thank you very much.